Keratoplasty in cases of primary congenital glaucoma by Dr. Muralidhar Ramappa.
Good afternoon. I shall be presenting the long-term functional success of penetrating keratoplasty, particularly in children with primary congenital glaucoma, 28 years of our experience. I do not have any financial interest or a relationship to disclose pertinent to this particular talk. As we all know, primary congenital glaucoma is a rare disorder with estimated prevalence 1 in 10,000 in West, and this seems to be 3 to 5 times much more prevalent in Indian subcontinent, owing to many issues. They're mostly sporadic, and we found and established the CYP1B1 has a founder effect in these cases, and 2/3 of them, majority of them are bilateral. They do manifest before month, first year, and those which have an early presentation tend to be much more aggressive and likely to end up having an irreversible corneal damage. So you have a typical triad which mainly attributable to the epithelial edema owing to intraocular pressure in the early stage, and horizontal corneal diameter seems to be one of the important marker for the disease progression. And mostly in Indian setting, early on you see a stromal edema directly related to the rise in intraocular pressure. As the disease advances, you tend to have an endothelial decompensation, then it sets the irreversible corneal decompensation. These are basically sequelae which we tend to handle in a cornea clinics. There are certain times eye drops can actually reverses following a control of intraocular pressure. And this is a very classic case how a PCG actually manifests. You not only have an enlarged white-to-white diameter, stretching of the limbus, and also rise intraocular pressure. These are the hallmarks. And also color is a bluish white, unlike Chet. Also, one is a typical thing about here is optic nerve is much more pliable. It tends to show very aggressively changes to the intraocular pressure. Once you control pressure aggressively, it can reverse, but not necessarily visual fields. In nutshell, corneal edema are a consequent changes within the corneal stroma, abs striae, or uncorrected refractive error, or amblyopia, or even the progressive optic nerve damage can actually result in a consequent poor vision in these cases. There are certain peculiarity when it comes to transplantation in these children. You have a distorted architecture of these eyes, which makes much more vulnerable and end up having intraocular catastrophic complications at times. Even postoperatively, again, a big issue is the controlling intraocular pressure. In a long run, this succumbs to infection, rejection, trauma in these younger children, and any repeat intervention for a cataract or a glaucoma can also impair long-term outcome. And repeat intervention seems to be very poor here. And with this background, since we know PCG is one of the poorer indications for a pediatric transplantation, with that intent, we aim to see what is the actual benefit of doing a PK, particularly in a PCG. We had 1128 eyes of 653 children who had a glaucoma filtering surgery, and about 10% of these children eventually had irreversible corneal damage. Finally, we did a 209 transplantation in 150 children. I'm sorry. So I'll just skip to the tables, and this was the numbers which I was talking about. As we know, it is a male preponderance, 2/3 were bilateral, 1/3 had a parental consanguinity, and most of them had a presentation within 1 month. You can actually see the distorted architecture. And we waited nearly 10 months, so it is a 5 to 2.4 years, and we gave enough time after controlling intraocular pressure to attempt a PK in these cases. And we had a 61% of the grafts were clear with the longest follow-up. There's a very busy slide talking about complications following a PK. Even though before embarking on a PK, IOP was controlled, and about nearly 25% of them end up having uncontrolled glaucoma following a PK. Graft infiltrate, again you can see in a time frame, first year is a much more prevalent, and graft failure, and very less number of allograft rejection compared to other indications. These were the reinterventions, and about 16% needed AGV to control intraocular pressure. So 140 had a first graft, 49 had a second graft, 50 had a 3 grafts, and 5 had a more than 4 grafts. If you look at cumulatively, so intraocular pressure control is the key factor here. Second, again, infection, we have to deal with that. And also glaucoma drainage device seems to be one of the important risk factors. We put all complications in a multi-mathematical regressional model. What it shows is IOP is the key here. And nearly 50% of them had ambulatory vision. And our median survival was 10.3 years for a first graft, 5.8 for a second graft, and 6.9 for, this was because, immunosuppression and AGV and so on forth. We did compare head to head with our older data. Unlike in older data, allograft rejection was a principal reason for the graft failure. In this particular uncontrolled glaucoma seemed to be one of the important risk factors. These are some of the best case scenarios. And the same thing has been mirrored even in a published reports. If you look at survival of graft in presence of a glaucoma, seems to be abysmally poor in comparison to the counterpart. So with this, would like to conclude, although it offers a decent long-term success, but it is an high-risk scenario, and though they have a decent improvement in the visual functions, it often limited by the optic nerve, head damage, and amblyopia. So the key is IOP control before embarking on a transplantation. And the way we measure intraocular pressure gets confounded post-operatively because anesthesia effect and a corneal edema can also underestimate. And also the reversal of optic cup can actually deceiving. Therefore, even a surrogate measures like an expanding corneal diameter, visual field assessment, wherever applicable, should be considered in addition to intraocular pressure. I thank all my collaborators, and thanks for patient hearing. Thank you so much.